So do you use the RX for pre-surgery at all?
I mean, I use it on all patients. I don't just use it on surgical patients, but I mean, I just don't really treat a surgical patient without it any longer, because there's so many neurological issues that come from having surgery and having those injuries. But I do it pre. I did it pre-op for a rotator cuff tear, to get him some strength before he went in for his shoulder surgery recently. Injuries, I try to get him back moving. It has like multiple uses, but there's so many neurological things that happen when we get hurt that we as PTs or massage therapists or chiropractors or any of that, we can't really address. And that's the continuing lagging thing for people with injuries, is that neurological feedback. And so the faster you can change that neurological input to the system, I feel like the better they are, the faster they can get back to activities they want to do. Those people that are like, they're going to go ride their bike, surf, kayak, run, no matter what you tell them. It is their life. They're not going to give it up. Those people instantaneously, or they're like, how fast until I can do this? Like, I've got this timeline, or, hey, I know I'm injured. It's this, I'm still going to compete. Like, what do I have to do to compete? So those are those ones, absolutely 100%. I'm going to suggest using the ARP Neuro on them. The other people that I do go to is, a group that probably doesn't get talked a lot about is a geriatric population that still wants to do things, but, their bodies just aren't healing as fast as they want them to. And they have all these compensations, and they have disc issues, and they have all these back issues, and they've tried everything, and they don't want to do surgeries, and that's the only thing. And I had a woman like that with really bad stenosis, and I was a little worried because, the ARP is amazing. It's just not the most comfortable to start with, and it's not really pain. It's just not anything you've ever really felt. And so some people, you're just not sure how they'll tolerate it. So I recommended it to her. She's 84, but still works and does all her stuff and exercises. And she couldn't sleep. She couldn't stand up. She couldn't walk her dog. She was terrible. So I was like, well, let's try it. So I put the pads on her in our back and like in through her glutes. And then we just did some sit to stand stuff off of a chair and just did neural reset. I was kind of like worried about what to do with her with it. And she thought it was the best thing since sliced bread. Like she slept that night for the first time. So those people that have tried everything is another one. And I think that's where I do more of the seeking with like the pad and try to figure out, maybe it's not what everybody's thinking, that the compensation is coming from something else, or the dysfunction is coming from something that we're not looking at, that we're looking at pathology on a MRI or something like that. And maybe that's not really what it is, or all boiled down to. So that's a group of people I use it with as well.
Essentially what she's talking about is you're going over with a clamshell pad, a sponge, and it goes over certain areas. In some cases, you just feel the regular pins and needles or the contractions, no problem. And then it'll go over a certain area, and we call it a hot spot. We used to say it'll light you up like a Christmas tree, and we would consider something like that, the area that we would anchor a pad. And essentially our hypothesis behind that is that, because it's contracting at 500 times a second, that particular muscle isn't able to absorb that type of force. And you're not really able to detect that when you're just going normally, when your brain contracts a muscle around 20 times per second. But when something at 500 times per second starts to blow out that area, it reacts differently. And again, like Cari said, it's not pain, but it's certainly intense. And it pulls out some of those locations where you're like, okay, now we'll anchor the pad here and see what happens. And a lot of times it's not even in the close proximity of where the pain is.
It's nothing that we have as an ability to do. Like I've put it on people's ankles when it's their backs, it's like, really is you think it's going to be their back,
Right.
if it's a back patient, and you scan their entire back and they're like, well, this is where it hurts. I'm like, well, that's not where the problem is. Like,
Yeah.
like this is what's lighting up. So let's try that and see how it works.
When you see their reaction afterwards, where it's like, you didn't even treat my back, but essentially afterwards they're out of pain. So it's like, you treated the back, but it wasn't the back that was the problem. It was something else.
Yeah. And that's what I tell people is like, it's that neurological input that's causing you to change how you move. Right. And that's what we're trying to fix, is how you move. Like, I'm not going to change somebody's disc disease, and I'm not going to repair somebody's ACL or whatever it is, but we're going to change how you move so that you're not creating all those muscular contractions in an improper manner or in imprecise manner or a sequencing issue, whatever it may be.